motion.
That the items on the agenda constitute official business of this board meeting. Meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans considering the COVID-19 outbreak and any conflicting with the governor's executive order permitting electronic meetings be suspended.
All right, is there a second for that?
Second.
Great. All in favor by show of hand, please. I see you, Carol. Carol, I actually see and hear you if you think you're having difficulties. We actually see and hear you. All right. All right, I see you. All right, everyone votes aye. Dr. Campbell is not on the meeting. So there you go, Martha. Great, thank you, Ms. Franklin. Minutes for September 10th.
Dr. Jahanger, excuse me.
Yes.
I need to mention one thing about the methods of taking votes. The governor's executive order now imposes a requirement that all votes be performed by either poll or roll call voting.
All right, great. Thank you for that clarification. So we'll roll call this. I'll do it on my screen here. Dr. Smith.
Present.
No, it's an aye, no, or abstain.
Aye.
Thank you. Ms. Etherington.
Aye.
Mr. Frederick.
Aye.
And Ms. Franklin.
Aye.
And I also aye. So thank you. Thanks for that clarification, Derek. Minutes from September 10th, 2020 were circulated with our packets. Any clarifications or motions for approval or not?
Approved.
All right, motion with from Ms. Etherington. There's second. Ms. Franklin, second. Any discussion? All right, I'll do a roll call. Dr. Smith.
Aye.
Ms. Etherington.
Aye.
Mr. Frederick.
Aye.
And Ms. Franklin.
Aye.
And I also aye. Okay, thank you. That carries. I'm going to defer this part of the agenda to Ms. Etherington, and we're doing an approval of a letter to family of Ms. Gregory. So, Carol, would you mind leading this discussion and calling for the motion when it's time?
Absolutely. In our last meeting, I was asked to take some responsibility for putting this together, and I had the really wonderful opportunity to go out to speak with many of Maryland's co-workers, supervisors here at Lent, and it's very clear that whatever letter I might piece together with Martha's help, I will add, would not do justice to Marilyn Gregory. But I'm going to submit this to you. The bullets are clearly comments from her peers. But what they had to say, we didn't interview patients, but it was very clear that many, many patients have such regard and feel such a sense of loss that she's not sitting there when they come in the door. So I think that if y'all have had a chance to read it, you can make any comments or additions or detractions or whatever you would like. And what we'd like to do is send this to Ms. Gregory's family.
Just curious, was she good at her predictions of the sex of the gender of baby?
Well, apparently, because everybody talked about how if a worker or an employee was pregnant, that just took over everything. And I can just tell you that to a person, they talked about how when that baby was born, she never forgot that baby's name, and all through the years after that, she added her children just down.
Carol, what I noticed here was the fact that you shared with us that she was Metro Public Health Department historian and site the past 40 years. And so that knowledge is amazing. And so that really is a testimony to our workforce and how she modeled that. And I want to say thank you to you for taking this on.
Absolutely.
And not only that,
to do
going to actually hear the story. I really do.
And what I had hoped to do, if anybody from the East is listening to this, is to draft a letter and then send it out there for the review. We absolutely were on such a time frame that it was not possible. do that. So they'll certainly get a copy of it, and I hope that they are okay with it. But honestly, I'm not at all against, again, please critique it any way you want.
I appreciate this.
Yeah, and from what I've heard from you all and others, I mean, I'm saddened by our passing, and I appreciate what you've done here. So with that said, I mean, I guess I would formally motion or ask Carol if maybe if you'd like to motion for us to approve this letter as you've written it, and then for all of our signatures, and at least we can show a small token of our gratitude to her family about all she has done for our great department. Is that fair? All right, motion for Carol.
You don't want, if you rather someone else do it.
Second.
All right, so Mr. Frederick and Ms. Franklin is what I heard. Any further discussion? If not, Dr. Smith, aye, nay, or no?
Aye.
Aye. Ms. Etherington?
Aye.
Mr. Frederick?
Aye.
Ms. Franklin?
Aye.
And Dr. Campbell, welcome. I need you to verbally say yes or no. You're muted, sir.
Yes.
All right, thank you, and welcome. I also say yes. So, it's Mr. Smith, Dr. Campbell. I don't know if you heard it. He was pretty on. We have to verbally roll call. So we'll go to the lawyer. So thank you. All right, thank you. And Carol, thank you for, yes, ma'am.
You're welcome. There are three of us who will be signing this here, and then Martha will be connecting with others of you not here to get your signature.
Okay, great. Thank you. Ending the HIV epidemic update. Thank you for joining us. So, who is doing that?
Julie Thacker. I'd like to introduce her. Julie, are you on? Oh, there you are. Okay. I'll let you take it from here, Julie. Welcome.
Thank you. So I do have a presentation, and I believe that I will have the ability to share my screen. I do not have that ability. Stephanie? Or someone else from IT?
Is anyone able to assist?
Great, thank you. Okay, and hopefully you are seeing my slides and not my notes.
No, this is great. And then could I ask, could everyone please mute who's not speaking? Thank you.
All right. Well, thank you for allowing me to present this evening. I know you have a very packed agenda tonight, so I will be trying to keep my update brief, and we'll be providing a little bit of background on the Ending the HIV Epidemic Plan of Nashville, the approach we're taking to implement the plan, some of the progress we've made so far, and some of the key challenges that we've been experiencing. So a little bit of background on the plan for those of you who are unfamiliar. The EHE Plan of Nashville was developed in 2017 and 2018 and led out of the mayor's office with over 100 stakeholders and partners participating in its development, which resulted in the 5-year plan to end the HIV epidemic in Nashville and the 6 goals that you see on this slide. The plan was developed prior to the release of the national plan by the Trump administration, and Nashville is not one of the cities that was prioritized by HRSA for the first wave of EHE funding. And is anybody else hearing hold music?
Yeah, seriously, could you guys please there are several unmuted people on this phone.
All right. Thank you. So I was hired in December December of 2019 to manage the implementation of the plan. And my position is currently the only implementation funding for Nashville's EAG plan. And I also serve as the liaison to the EAG Advisory Council, which was created by executive order in 2019. So I'm just going to talk to you a little bit about the approach to the implementation of the plan. There are dozens of strategies, so it was necessary to begin by prioritizing for both impact and feasibility, and the Advisory Council did so in early 2020, resulting in the 5 areas that are shown on this slide. Other emerging priorities are being considered in light of COVID. However, all of the work being done so far is aligned with these 5 areas. We are working on implementing some priority projects. However, most of the work is emphasizing capacity building. So, in order to achieve the goals of EAG and long-term sustainability, we've been focused on relationship and partnership development, the infrastructure of the implementation, and training opportunities to help us build our capacity as a collective impact initiative. And eventually, my hope is that EAG is written into the job functions of stakeholders and other EAG organizations serving on work groups and leading projects in order to help with sustainability and the shared leadership approach that is critical to collective impact. So collective impact was the approach that was recommended in the plan and has become the standard for how the health department and other partners work together to address complex population-based issues. The 5 tenets of collective impact are having a backbone organization. That can be one or more organization providing different backbone functions. Currently, the health department is the sole backbone and serving as the administrative lead. The common agenda is, of course, the EAG plan and the priorities. And the other tenets are mutually reinforcing activities, shared metrics, and continuous communication. And the graphic on your screen shows that so far, in addition to the Advisory Council, a leadership team has been established, as well as an equity work group and a trauma-informed care and cultural humility project team. And finally, regarding the process, systems change work isn't new or unfamiliar to me or many of my colleagues in public health, particularly in the Population Health Bureau, who have for years been working in with these types of complex, large-scale social issues. But it is a new approach, specifically in the HIV prevention and care continuum. And what this graphic really shows is, no program, no policy in of itself is going to end the epidemic overnight. The plan includes dozens of strategies, and while it's tempting to go after low-hanging fruit, we know that those aren't going to make the progress that we committed to with EAG. The plan deals with complex intersecting issues like stigma, discrimination, and trauma, healthcare access, and social determinants, populations feeling mistrust in the healthcare system, and those things are really complex to overcome. It's going to take a lot of work building trust and relationships among partner agencies and with the community in order to achieve the goals in the plan. So moving on, just a few key projects that are currently underway. The Equity Work Group is working on developing metrics for inclusion and an equity lens for applying to all EAG projects that move forward. The Trauma-Informed Care and Cultural Humility Project team is working on assessing facilitators and barriers to implementing trauma-informed care and cultural humility interventions in the HIV care continuum. And a World AIDS Day 2020 planning team has been formed to start planning several events leading up to the December 1st World AIDS Day under the theme of Let's Talk About It, Know Your Status. So we'll be promoting community testing events, but also creating opportunities to talk about the importance of testing in Nashville and everybody knowing their HIV status. While I came into this role just, 2.5 months before a tornado and a pandemic, Things have been, going pretty well for the most part, but some challenges that we have experienced are in the areas of testing. So HIV testing has dropped dramatically in Nashville. The Tennessee Department of Health shared that testing in Davidson County is down 30% for clinical sites and 40% for non-clinical sites from the same period of time last year. Organizations like Nashville Cares are doing drive-through testing events, and the state has an at-home testing program, but those programs alone aren't compensating for the drop. Social isolation has, always been a problem in the HIV community, but has become even more of a problem during COVID. Quite honestly, this has been up for discussion in many arenas, but we haven't really been able to find any solutions to implement yet. And it can be challenging trying to advance a mostly upstream initiative when many of our stakeholders are bogged down in the day-to-day of a pandemic. Especially challenging to get clinicians to the table who are key to implementing projects that are clinical in nature. But obviously, they just don't have the time or space to be involved. So in addition to everyone who contributed to the plan, I did want to acknowledge the EHE Advisory Council members, as well as the leadership team who are driving the key strategic work of the ending the epidemic, including forming additional work groups and the creation of our strategic communication plan. The equity work group, which is developing key equity projects and metrics, and our trauma-informed care and cultural humility project team that's working to build our local knowledge base. And also, finally, all of my colleagues at MPHD who are supporting the work in a number of different ways. So if you have any questions, I would be happy to answer if there's time, or take any questions by email or phone.
Thank you so much. I open the floor up for questions from my colleagues, please. Yes, Mr. Frederick.
Yeah, I have a few questions. I did see a newsletter from In the Epidemic that Nashville Cares has started its trauma-informed mission with theirs, and I didn't really know how that was panning out, hopefully well. But you mentioned that testing is down. What about the positive results? Are they down? Are they the steady? Or what are we seeing as far as the number of people that are testing positive based on the lower number of tests?
Thank you. That's a good question. So we haven't, from the health department, been doing beyond, of course, what's happening in the clinics and the additional outreach events currently, but I have heard from Nashville Cares at their drive-through testing event that they held last month that they had 2 positives from maybe 20 or so participants there. And then the state, from what I've talked to with Bob Nelson at the state, that they have received, basically over they're definitely over the 1% threshold of HRSA to maintain their funding. I think the last I heard was 4 positives in the last quarter from the at-home testing program.
But who's aggregating data on these? Down, but then they a little bit more so is there some aggregation of the data for this group? I realize you're a one-person show, but is there someone through Ryan White, or is there some way to aggregate this data and report out a little bit more?
So I'm sorry, you cut out for part of that question. Can you repeat it?
Yeah, I'm looking for how do you aggregate the data so that you know whether or not we're making progress? You're a one-person show. Are you getting your data through the Ryan White Consortium? How are you getting that information? Because you knew how many tests were down, but it seems that your knowledge of the positive results was a little bit more anecdotal. So I just wonder who's aggregating.
Yes. So I am connected with the Ryan White program here as well, my colleagues and Ryan White. I can ask and certainly follow up to see if we can get an accurate number of positive results for you. And
I guess that's sort of, if you've got a one-person operation, and I think you have some other duties as well, I've heard recently, and I don't know how this initiative can sort of be kept moving forward if it's not properly staffed and there isn't anyone monitoring. If we've got certain strategic goals out there, but there's no way to monitor it, then that makes it rather difficult for us to have any success here. I don't want to feel like we're just having a program for the sake of having a program.
yeah, no, I mean, that's a very fair point. I think with the health department, we're used to working with limited resources, and part of my role is to build and find additional resources to support EHE. I know that the plan was actually completed at the end of 2018, but the advisory council wasn't established until late last year. And like I said, I came into this role 9 months ago, right before a pandemic. So the focus is certainly on capacity building. But again, a lot of this work really is in building trust and relationships. So
okay, and I totally understand that. I just want to make sure that we, again, don't have it sitting out there and lose sight of it. And then I would say that I don't recognize any of the names from your advisory group that have any connection to Music City Prep. They have become extremely active over the past 12 months, and I would hazard a guess that they probably are prescribing well over half the prep in Davidson County. So that is a group that you should reach out to from that perspective, because I think they are very plugged into the young, sort of more social kind of folks out there.
yeah. So the advisory council, as of their last meeting, has approved a nominations and recruitment plan, and so nominations are open to the advisory council currently, and I will make that note to them.
Okay. Thank you very much for the update. I do appreciate it. And I know that, like so many things, I think it's sort of the COVID pandemic, sort of, if you had a program that just started and this comes along, and then it's hard to keep it on track. So I think this is just sort of, for me, indicative of we can't lose sight of our regular jobs while we're trying to fight this pandemic. And I think that's just something I would want to make note of.
Thank you.
I have a question. I would imagine that one of the reasons that testing is down is because students have not been on college campuses in the numbers that they're traditionally on, but some are still taking courses. Could you talk a little bit about how you're engaging with college campuses, with student groups, in terms of maybe thinking outside the box to reach that particular demographic? And I'm talking about CSU, State University, Harry, Vanderbilt, Belmont specifically.
Yeah, so that's a really good question. I think a lot of the testing, so I think I had said that it was 40% down from the outreach. A lot of people who were doing outreach testing because of their organization's policies are now no longer going out into the field. So that's, an aggregate number for all of the groups that are testing in Davidson County. And then also being still restricted by HRSA's 1% positivity guidelines, makes it kind of challenging to try to implement innovative testing initiatives. That said, TSU in the past, I know from my colleagues at the health department who've done a lot of outreach with TSU in the past, and other universities and colleges in Nashville is one of our key missing, groups right now. We're hoping with World AIDS Day, where the focus is on testing and pushing out that message of knowing your status, that we'll be able to, and somehow connect with those groups.
Keep in mind that World AIDS Day, like you said, is December 1st, and by then students are not going to be here. They'll be in an exam period, especially TSU, which is I believe a Board of Regents school. So just keep in mind that timing, and And thank you again for the work that you're doing. Education is key. And I know Dr. Ariola, when he was here, he had talked about making sure, engaging specifically to HBCUs, because that was a demographic where we had a disparity with regards to.
Right. And I do know that Nashville Cares has a program specifically designated for outreach as well. So that, and I would imagine that they are now running their own prep clinic as well for that and have a special clinic.
For college students?
It's not, I don't know if it's geared for college students so much, but it is located in Antioch, so it's probably more community-based, to be honest with you. Yeah. I'm a little bit not as in touch with them as I used to be, so I'm not sure.
Julie, thank you for the work that you're doing. I appreciate it. I know it's hard, and so our questions are designed to bring awareness, and we appreciate you and your team that you're working with.
Thank you.
Thank you so much. I appreciate your giving us the update.
Yeah, ditto. Can you mind stopping your sharing, please? And again, I share my colleagues' sincere gratitude. It is, as Derek said, we got everything going on. We want to make sure we never lose light of the really important work that this department does. So thank you. All right. Before I have Dr. Caldwell hop in here, Carol, you had mentioned you may want to talk real quickly about your meeting with the opioid group. Would you mind doing that now? And then we'll hop into some of this real quick.
Yeah, I'm glad to do it. I just lost myself again. I don't know what it is.
You're right here. We all see you. It's perfect.
Well, just very briefly, on the heels of our last meeting, when we were sort of staggered by some of the statistics, I asked for some additional information and was invited to join Angie Thompson and Trevor Henderson and Josh Love. And for 90 minutes, I listened to an incredible overview, far more in depth than we could get in the board meeting regarding the opioid crisis, and particularly the focus on fentanyl. And in hearing what they had to say, it became even more frightening to me. And part of the reason I wanted to have the meeting, or I actually just wanted some information, and they were gracious enough to give me that time. The data that we're collecting in this health department via Josh Love is pretty amazing. And I can't say I walked away with anything more than a much greater understanding of how vast the problem is, what our relationship is with law enforcement, what this team is doing. So I walked away with a really good feeling about the team and the health department. I did not walk away with a good feeling about the prospect of anything new occurring to lessen the deaths of opioids, particularly this year, which, if you remember our last meeting, was pretty staggering in terms of the numbers of deaths outpacing last year and a year before that. So when I asked them what was the most, what would be the most helpful way the board could support their work, and they said, well, actually, one way is to do this kind of thing of having a more in-depth understanding of the nuances, which they really can't talk about publicly, because a lot of what they do has to be really sensitive due to the victims, which, by the way, they told me often these deaths are referred to as victimless crimes, when in fact, of course, they're not victimless crimes, because fentanyl is being sold, and most people who are buying it, if I understood correctly, do not have any clue that fentanyl is in what they're buying. So it is a health department, and it is a law enforcement issue, and I was so proud to hear them, and I just wanted to bring it up, and I said that I would like to encourage, with everybody's busy schedule, to try and carve out a little time to go and this trio and hear some of what they have to say, some of the statistics, which we just don't have time to do in a board. But it is compelling. It's compelling, and each of them made very dramatic. This is one of our most critical public health issues. And the one which left is also critical. But this one one of us, as we are able, to just call Angie or Trevor, whomever, and set up a time to go and meet with them down there. It's really remarkable.
Great, thank you. Thank you so much for doing that. Okay. All right, now in the next block of time, Dr. Caldwell is going to, what I hope actually relatively kind of a big overview, but not long, just a quick overview, strategic plan, accreditation, and organizational chart, and then what I update. And before we go down this discussion around the org chart, I want to be very clear to everyone at the front end. What I hope to get out of this discussion is exactly that, as a discussion. I think Dr. Caldwell and his team have spent some time speaking to the ELT as well as to board members about the org chart, and I know it's taken a lot of effort, and I think it's really important. But today, there's not going to be any action on the org chart. I want to be very clear with that. This is just for us to allow some more open dialogue. And then between now and November, at which time maybe a time we do take action on the org chart, I want to be very clear with and ask our colleagues on the ELT, especially, these are people most impacted directly, to reach out to us as board members directly, to comment both positively and negatively. I think it's really critical. If you think this is a good idea, we need to hear about it. If you think it's not a good idea, we want to hear about it and hear productive thoughts around this. You can call, email us. We'll keep your confidence if you want. If you don't want to be public, that's fine too. And then if you want us to, and then what I'm going to let is if anyone would like to publicly address the board at the next board meeting, please let me know, and I will make sure you have the opportunity. This is about your department, and I want to make sure everyone has their voices heard. So please take that message clearly, that the board wants to hear from you. Please reach out to us between now and next month. If you want to speak publicly next month at the board meeting, let me know, and we can do that. I think that's what I want to say. But again, what I hope is in this short time here, Dr. Caldwell, if you could, again, you spent a lot of time already chatting about the org chart, but we can hear from Ms. Larson about strategic plan, accreditation, org chart, and then most of this time I'd like for a dialogue amongst the board and questions to the staff as needed. So with that, thank you all, Dr. Caldwell.
Thank you, Dr. Jahangir. I was going to move forward with this part of the agenda, but I was going to also wanted just to bring to your attention and recognize we have two additional members who have joined us to give an update on the data sharing, Mr. Keith Durbin, the chair of the Metro IT, and Mr. Stephen Martini, the Department of Emergency Communications. So with your permission, I thought perhaps they could give their update to the board on that issue, and then I could proceed with this.
They can roll off. I'd be fine. Thank you. That sounds like a good idea.
Okay, thank you. Mr. Durbin, you're recognized. Thank you.
Thank you very much. We appreciate the opportunity to be here. And the team and I, and it did take a team effort, appreciate the opportunity to work to share this important COVID status data between Metro PD and the health department. And that's based on the work that was done by the data group, which was led by Dr. Campbell. As a reminder, there were two different use cases to sharing data that were identified based on the work of that data subcommittee. First off, there was providing medical first responders in the Nashville Fire Department information based on health department records. And the second, there was the second use case providing public safety staff with information upon need for transport of individuals. And rather than me report on them, what I'd like to do is kind of let the two departments who actually are responsible for those things and getting the job done to report on those. You mentioned Steve Martini, who is with DEC, but we also have with us John Singleton, who is the director of IT for Metro PD, to share their progress. And so, Steve, you want to take it?
Durbin, I'm wondering if there's anything in writing that could be emailed to us so we can just have something to anchor on. We're just completely flying blind, or if you have notes, if either of those that are presenting have a presentation that they can share.
We'd be happy to follow up with something, but no, we don't have anything prepared right now. But we're happy to follow up with you with the documentation from prior meetings.
Thanks, Keith. The solution that the Department of Emergency Communications has been working to implement was the identification of the addresses of COVID-positive patients. As of yesterday, we successfully tested an interface between our Motorola computer-aided dispatch system and the Department of Health database to identify addresses and notify the dispatcher of addresses where a COVID-positive patient is actively located. And that is inside of that 14-day window. If it's outside of that window, the dispatcher would not be alerted to that location as that of one that responders need to take maybe extra precautions for. We expect to finish up that last bit of testing tomorrow afternoon regarding how that alert appears to the dispatcher, and then we'll be able to train on that next week. I'm glad to take any questions.
And then we'd like to hear from John as well, if we are able to, on the police transport side of things.
Yes, it's John Singleton. We have completed the search query development to query against the secure health department server when officers need to be able to do a query on transport. And so that development effort is completed as well, and we are ready to implement that whenever it is determined. We've developed some draft roll call training information that will be sent out to all police officers at the appropriate time, right before it is approved to begin activating this query.
We don't hear you, Keith.
Yep, so we'd be happy to answer any questions about that. And we certainly will follow up with an overview, and sorry for the oversight in not sending something out about the progress that had been made on these. I don't know whether Dr. Campbell had any comments based on the work that he led in the data sharing subcommittee, which all of this work was based on a number of meetings that were held led by him.
Yep. Any questions, thoughts? This is a...
I'm not prepared to ask any questions because it wasn't on the agenda. So
yeah.
I follow-up information to review. Maybe we can ask questions later if that's okay, Mr. Durban?
Absolutely.
And let me
Happy to do that.
And I'm just sorry if I missed this, but I mean, I know we as a board have approved the process. Did I miss a timeline of when this will roll out? Is this like tomorrow, next? I'm sorry if I missed that. I apologize.
So tomorrow, the DEC will have theirs ready to go, presumably with your approval. I'm not sure whether we were looking for approval to do that.
I think we've already provided approval because that's what led to, but just updates what we're getting.
Yes, and so that will roll out tomorrow. And then what I think I just heard John Singleton say is they're ready to roll it out through their roll call training processes. And John, did you have an idea of when you thought that might happen?
That can happen as early as Monday or Tuesday. I would suspect it'll take us a day or two to roll out that roll call training and give the officers enough time to consume it. And then we'll be ready Monday or Tuesday, if that is, if we're ready to go.
Okay, thank you. What I'm going to ask is Dr. Caldwell, between now and the next meeting, communicate with us when things are rolled out and follow up with, as Mr. Durbin said, is the protocols.
I want to be sure, I mean, and I could be wrong, but I thought we were looking for, because what we had said, we had an idea of how we wanted it to work, and then we're going to go see if the technology would support that. But maybe we did actually approve sharing it in that manner, but I'm not certain that we did, and I don't feel comfortable that I understand what the process is today. I heard you describe it, and it sounded like what we talked about, but I'm not totally certain of that. So just, I'm not trying to be a obstructionist. I just don't know that I'm hearing.
So, Dr. Caldwell, I'm going to defer to you to answer this question since you brought this up. The agenda. I agree. Please.
The board passed the plan, and it was brought to our attention the plan could not be implemented for a period of time. The board was not comfortable with that, so they also passed an interim plan. And so today I'm updating you to say that the interim plan will be transitioned to the original plan the board approved moving forward, and that's happening imminently. So I wanted to make sure you were updated that that interim plan, which was not as attractive as the other plan, will be transitioned to the original plan that the board approved.
So Martha was kind enough to volunteer to sign the minutes from the previous meetings. I'm also concerned that, one, we're discussing this, like I said before, and we just didn't have a chance to prepare for this discussion. And so I'm not comfortable just moving forward until we are clearly aligned on next steps. So if we're talking about action in the next few days or next couple of weeks, that's before the next board meeting, that's just a lot for us to sort of reflect on right now, considering we haven't had an update on this in a couple of months.
Did we not, I'm sorry, I didn't mean to cut you off tonight.
I want to pull back and just make sure that all of us are aligned as a board and comfortable moving forward with the information that we have.
Did we not, I would like to see the minutes as well, but and police, and Dr. Campbell, you've been kind of leading us. I thought we as a board approved a process that, and this was an update. Again, this is hitting me new too right now. But I thought, my understanding of our understanding is we had approved a process. That's what gave the green light to Mr. Durbin and Martini and crew to move forward. But Mr. Campbell, or Dr. Campbell?
Yes, that's my understanding. We passed an interim plan until this permanent plan could be instituted, and we were, as I understand, they're telling us it's good to go, and it's kind of ahead of schedule.
It's possible that you are correct, Dr. Campbell. I just think that from my perspective, I haven't seen what is supposed to start happening on Monday, so I just don't know that what we thought we agreed to is indeed what's happening. And it may be. It may totally be.
No, that's fair to make sure what we approve, what we all always approved. We don't approve it. It's consistent with what's being rolled out. How best can we communicate that and show that that's happened or happening? Written plan?
Yeah, I'll work with
if there's a written plan that matches the motion that was passed, I would be okay with it.
So we need to see that first. The pathway report out, which is really helpful to update. That I think what you're hearing is that all of us just need to see it and reflect on it, and just do our due diligence.
This is Dr.
Better, and I'm happy that we're headed there. I just want to be sure we don't get back in the same issue we were with people being very upset about information being shared.
Yeah, I'm with you.
Well, so this update for the board was just to inform the board what the board had already approved. The board has approved the plan. Mr. Durbin has fulfilled the role to the operations to be aligned with what the board approved. And because there was a concern by the board that the data should be shared more quickly, a less attractive interim plan was put in place, which is currently in place. So I'm pleased to be able to say and update the board that now we are going from this less attractive interim plan to the full plan that the board has approved. So there's no action required by the board. I think as long as Mr. Durbin could just reassure the board that actually what they're turning the key on is exactly what was approved, I think that's what I think I hear the board asking.
Well, I think the board, I mean, I need, as I believe, Ms. Franklin, if I'm hearing you right, and I agree with this, if I heard you right, let us see what is being done. But I also know as a board, we approved a plan, and I want to see that plan. And what I don't want to do is go through this over and over again. Like as a board chair, I think our board, we've made a decision. We've now deployed resources. We've deployed Dr. Campbell's committee, which had a lot of stakeholders on it. I think it is important that we see what is actually, what is rolling out is what we agreed to. I think that is critical. I do think, Dr. Caldwell, that it is our prerogative to say what I think needs action or doesn't need action. And I don't believe, I think it is very appropriate for us to make sure what's being rolled out is what we all agreed to. I am not sure it necessarily needs a vote per se, but I think it's fair to have, once we see this, if there needs to be some dialogue around it, then we can maybe bring it up again. But I don't think, let's just step one, let's just everyone see what has been brought up and compare it to what we approved. And there's ways we can dialogue if need be before things, but I hope we can get that information in the next, several hours, day, by tomorrow. That'd be very helpful if that's possible.
I'll ask Mr. Durbin to work with Mr. Campbell and to provide to you as the chair
everyone,
to all the board members, and that then we can decide whether that meets the ability for them to move forward. Because I had, okay, well, that's what we'll do.
Oh, I do appreciate Dr. Campbell, but I think it should come from the department with it being vetted by Dr. Campbell. So Dr. Caldwell, you and your team could probably write this up, let Dr. Campbell see it, and then share it with us. But we just need to see what we agreed to.
Yeah.
Before we release it out into the universe. We just want to do our due diligence.
Yeah, so can we make sure everyone has that plan? Dr. Campbell and everyone on the board should review it. Martha, if you can make sure we have the minutes and of what we agreed to. And then obviously we all have notes and recollection. I think that is critical. I agree, but just
Dr. Hanger?
Yes, who is that? Yes, Keith.
This is Keith. So I can, by early next week, mid next week, we can have full documentation for you. We'll take the documentation we have in place today, and we will put it in a format that is digestible because it's technical speak at this point, and I'm not going to commit to do that in the next couple of hours. So we were happy to do that. Also note that one of the situations that we greatly expedited this for was the original deadlines that Motorola, if you will recall, there were, remember the months rather than weeks phrase. We expedited with them, and I just want to make sure that everybody understands that we came within the deadlines that we were talking about, because we understood the priorities around this, and I apologize for if we did not communicate fully to the board kind of the fact that we were going to meet the deadlines there. So we're happy to put that together and get that to you early next week.
Mr. Durbin, I want to say I appreciate the work that your team has done, and I don't think the burden of this is upon you. I think this is an internal health department issue. We need to know how we're sharing information. We need to know what the process is. So I appreciate your hard work in getting this done quickly. We just need to make sure that the actual process aligns with what we approved, and that's all we need to know. So thank you.
I agree. Thank you so much.
Ditto. So thank you for doing that. But let's just not roll out Monday until we review what you sent, Mr. Durbin, please. Is that fair with the board? And we can all deliberate as needed. And thank you. Is that fair? And this is totally, here it is. I mean, this is a big deal to discuss. So, all right. Is that fair, Mr. Durbin, Mr. Martinez?
Absolutely.
You are on the screen. There you are. And thank you for sticking around for the first 50 minutes of this, and we'll okay. Thank you. We'll look forward to that report. Yeah, thank you. So, Michael, I'm going to take that from your director report, please.
No, thank you. I very much, it came to my attention. They were ready to move from the interim plan to this one. I was really pleased about that. That's why we wanted to give the board the update. So we're ready. We know what to do moving forward on that issue. As for the strategic plan, I have Dr. Celia Larson, who is going to just present a couple slides to update the board on where we are with that, because our strategic plan, you probably know our 5-year strategic plan is concluding. and we're at the point where we're beginning the next 5-year strategic plan. So I'd like if Dr. Larson can get the ball to provide her update. I think she does, so I'm going to go on mute. Okay, Dr. Larson.
Okay, thank you, Dr. Caldwell. Sure.
You're on, and your slide is up.
Oh, thank you. Okay, thank you. So good evening, board members and attendees. I want to provide you some context for the brief overview of what I'm going to speak about in regards to the update, as well as this unit of strategic planning, performance, and evaluation. We are a staff of 3. Kashana Lawless, Tracy Buck joined me in leading and carrying out this work. I created this picture to illustrate the alignment, interrelationships, and flow of the unit's major areas of work. These components include the Community Health Improvement Plan, the Department's Strategic Plan, performance measurement and monitoring, evaluation, quality improvement, and workforce development. The strategic planning process will result in a number of priorities that will drive the goals and objectives. Based on those goals and objectives, we will identify and prioritize, identify and prioritize the department's program performance metrics. I'm currently working with IT to establish a dashboard that will provide the analytics to track and trend these metrics. And on a regular basis, this information will be evaluated and can lead to quality improvement projects, as well as identify areas of need for workforce development. This whole system can become an important tool for performance management. Although we work as a team across the areas, I do want to recognize the leadership contribution of each member. Tracy facilitates the CHIP and the community health assessment, as well as the strategic plan. Kashana facilitates the performance measurement and quality improvement activities, and I facilitate the evaluation and workforce development activities. So moving on to the strategic planning update, we've adopted the NATO approach to guide the strategic planning process that will be facilitated by Tracy Buck. As you can see, the process is defined by distinct phases. We anticipate about 3 months to completion. Committee and team members have been identified, and we're also currently conducting a readiness assessment, which will be followed by an orientation to the participants. The accreditation resubmission process is also underway. To give you some context, the original submission led by Angela Williams addressed about 100 measures with multiple associated documents for each measure. 11 measures were reopened by FAB, so we are deliberatively moving through the process together and/or augment the required documentation. Because of the pandemic, the Public Health Accreditation Board granted a 6-month extension to our original deadline, but we anticipate completing this by spring. Currently, I'm serving as accreditation coordinator through this final phase, although all team members, as well as many people in the department, are involved in facilitating the completion of this work. So that concludes this brief update, and more to come.
Thank you. Any questions regarding this? Okay. Very grateful for your work. This is a critical step for us to do.
Thank you.
Thank you, Dr. Larson, for providing that update on where we are with the strategic planning process and accreditation. I have provided each of the board members, as well as our leadership team my narrative, as well as a draft organizational chart, as well as an update of the questions I had answered originally for the Board of Health in the interview process, and a 1 page of 3 overarching goals. We will continue to have a process of communicating and interacting one-on-one, as well as in groups. I'm also going to, in the process of drafting a narrative on my outreach and feedback process, so that you can more clearly see that in writing, the steps that I and the team here have taken to approach the organizational structure and ideas for realignment, and how that has occurred over the last few months and is continuing right now. I'll also be providing an update on a job description and narrative for the human rights and health equity position, as well as for the assistant director position, as well as for the information technology position. So since you have already had a chance to review what I have sent to you, I will just pause for questions instead of summarizing what I've already written, as well as discussed with you on our one-to-one meetings, which are going to continue. And Dr. Jahangir, thank you for welcoming all of the senior leaders to reach out individually to each board member one-on-one. We know the restrictions that we can't speak to more than one board member at a time unless we're in this public setting. And I think it's gracious and great that each of you are welcoming the opportunity to get as much feedback as you can. And I look forward to hearing that, participating, and seeing if some adjustments can be made. So thank you.
Thank you. I want to reiterate that please, ELT members, feel free to reach out to any of us. And I saw Ms. Etherington's hand go up first, so please.
Well, he did. I guess my first question, going down what we viewed in terms of the design, you have 2 persons, both of whom are not full employees of the department. So you got one who we have to determine how is it going to be determined, because Dr. Bailey came on for 6 months, and then the other person you've got in there is also somebody on loan. So I don't understand how. I was sort of surprised to see names in the position at this juncture, but I was particularly concerned since neither one of them are fully engaged employees of the health department. They're engaged in the workforce, of course. They're both doing great jobs, but what's the deal with this?
I could take that one at a time. I had a conversation with our finance director, Jim Diamond, and Mr. Smith from legal today, and I'd like Mr. Smith to at least review the issue of Dr. Bailey being the medical director and where that stands. Derek, are you able to give some insights to the board on that one issue?
Derek, you're muted.
You're muted, Derek.
My screen now, someone else must have had me muted, I guess, because my screen is green. Can you hear me now?
You're very low.
I'll lean in. Can you hear me now?
There you go.
Yes.
All right. The investigation of exactly what is in existence right now is still ongoing, but what I've learned today is that the pay plan that was approved via a Metro Council resolution for year 21, which is this current budget year, and I believe that would have meant it went into effect on July 1, your department has 2 medical positions approved. And Dr. Bailey, as I understand it, is in one of those medical positions currently, but serves as a deputy director. Your current pay plan doesn't actually have an official position funded for deputy director. It just has 2 positions funded for medical doctor positions. Therefore, we're still gathering information and trying to reach a determination and conclusion as to exactly what the status would be with respect to Dr. Bailey.
Just trying to figure out who's who. Is Dr. Wright the second of those medical positions that's funded, or is that an opening?
I believe that Dr. Wright is the other person.
Okay.
Or Dr. Shakai be.
I think she's funded by a grant.
Can I answer that? Yes.
Please.
Yes. We have 3 medical doctor positions in the budget, two of which are on local funding. That's currently Dr. Bailey and Dr. Wright, and Dr. Shakai is funded via a grant. So the health department's pay plan has 3, two local.
Okay. Mom,
I think we can talk.
so can we talk about the other position?
Yes. The position of assistant director is proposed. Katie Stone has been loaned to us by the sheriff, and that's how she is with us now. So between now and next month, I'll be working with Derek on a pathway of how we can create an assistant director position. Also with the mayor's office as well, on sort of a longer term strategy of, what is the process to do that. So that will be more elucidated next month. What we will also be doing is trying to elucidate an interim plan until we can get to that other plan that would of course need to be evaluated and approved. So right now, the interim plan is just what exists, which is that Katie Stone is still here on loan by the sheriff, and whether that will be continue until we can figure out what that final path should be, or should there be a secondary interim plan? These are questions that will need more investigation over the next month.
So can I ask some questions publicly here? And I'd love to, again, we're doing exactly what I hope we're doing here in October, is having this dialogue. And it's rare that I've seen an org chart be made, especially one as comprehensive as the one you're proposing. And you have names in there, right? And I don't know, the civil service roles are something additional, but I would hope that if we reorganize the department in a manner in which you're proposing, which again is very thorough, why would one not open up a search for senior positions, 2 new senior level positions, and very well the 2 individuals you mentioned may be the best candidates for that. But I would just want us to make sure part of our due diligence here is we make sure we understand the process of how one fills very senior positions like that, because I think we have to be very careful to that. The other concern and question I have is Metro is in a hiring freeze right now. And until we know an answer regarding the referendum, as I believe it's called, I mean, we as a department, as a board, have not discussed what if we had to conduct a double-digit budget cut. And I don't know, I hate to deal in hypotheticals, right, because I don't know what any 3 months will hold, but I know enough to know there may be something that we may have to plan for. These are the questions I really would like to even get more guidance with. And I know we've sort of talked about it privately. I want to bring it up publicly. And then the final thing is the process that we discussed last board meeting, in which we are discussed previously today, and now subsequently, is is the process in which the org chart would be, in which, if I'm not mistaken, would involve the board approval, which we'll talk about, formally vote on in November at the earliest, followed by a council approval. So I just want to make sure everyone doesn't lose sight of that. This is a long process that we need to navigate. But those big things, money, how the positions are filled, and then the critical nature of those positions or importance in today's world are all things that still weigh on me. But I just wanted to put my 2 cents in there. Sorry to take the time from any of my colleagues who may have had more dialogue amongst us or questions. So anyone want to dialogue?
Would you want me to answer, or are you just making a statement?
Sure, go ahead, Dr. Caldwell, please answer. And then Mr. Frederick's hand, I think I saw went up, and then Ms. Kate. Frankly, I don't know if your hand went up.
I agree that the issue of the referendum is one that is on all our minds. And with that in mind, we are working with Metro Finance on immediate actions, which we're taking to do a hiring freeze and trying to identify savings. So with Mr. Diamond and our team, we've identified substantial savings to get us partway to what we would need to. But you're right, we hesitate to make any additional changes until it's more clear that what needs to happen with the referendum or not. So I believe that by at least getting us to November will give us more insight and giving us more of a sense of what will need to be. Does it need to be postponed further? And that's definitely something I am sensitive to and agree with. Most of what you see on the organizational chart is not new positions. It's mostly a realignment. And going to the other issue that you had about what is the process and in what format or org charts need to be approved by the board and then to the Metro Council. I know that Mr. Smith's also investigating and working on that as well. And I'd ask him just to give a brief update on his findings. And I do know that he still has additional work to do on that specific answer. So Derek, are you able just to provide some insight in where you are with your review on that?
Am I still unmuted?
You're good.
All right. Yes. One, we've spoken about, as Dr. Jahangir has iterated here today, the charter speaks to, that is the Metro Charter, speaks to board and followed by Metro Council approval of an organizational plan with respect to the divisions and the employees within the health department. I am presently investigating to determine the history of the organizational plans for the health department. And I'll be able to present that information. It involves, the Metro Clerk is locating information of a historical basis. And then we also have the minutes of the Board of Health over the past years that also contain information. So it's a process of accumulating all of that information, and it keeps and continues to come in to me. So people are working in that regard. Today, I'm not ready to give a final outline of what the historical precedent may be, and then be able to compare that to what the charter states, and then we can see where you go from there. And I'll be glad to answer any other questions if anyone has any other ideas of sources of information. But the minutes of this board, as well as the Metro Clerk's office, seem to be the repositories for the information about organizational plans and organizational charts.
Mr. Frederick?
Yes. Well, I may have jumped the gun, but I've already spoken with, I think, about 9 members of either the cabinet or the ELT to get some feedback on process. And I think that the process and the level of participation that you believe you got, Dr. Caldwell, may not be reflected by those people that I talked to. So I think that there needs to be some revisiting of how you're rolling this out, and because we must have buy-in of all those who are going to be doing this in order for it to work. I didn't hear anyone say they would not do it, but I did hear some conversation about that one-on-one meetings were held, and then the actual org chart that was produced did not match those meetings, and that there's been some consternation around that, and that needs to be clarified. When I look at this org chart, and first let me say, I think as the leader, you have the right to propose any organizational chart that you want that works for you. But when I look at this, I don't quite see it the same way that it was described by Dr. Jahangir. I see that there are 5 people that are now, in my world, what I would call vice presidents, reporting to a CEO. So there are really 5 positions that are being elevated above where others are. And I think that 2 of those currently are, I think, primarily medical clinical positions that will need to be backfilled if they take on administrative role, if that is indeed what's happening. So I guess I need a little bit, I'm not asking for this answer today, but perhaps we can have a one-on-one conversation between now and next month about how are those people that are being elevated, what is their role actually? Are they administratively responsible for those particular programs? Are they simply communication conduits? There seemed to be confusion amongst those people that will be working with this new organization as to what that meant. And so that certainly caused me to be confused. So I think that there's just an awful lot of process work that may need to be backtracked as far as how to get from point A to point Z, rather than just quite a quick jump there. And the last thing is that I also got the impression, and maybe this is perfectly okay, but that some parts of this new org chart have already been implemented. And I don't know to what degree that has happened. I don't know if reporting relationships have already been changed, but I think that anything about reporting relationships and as it relates to bureau level reporting, I feel it should be put on hold until we actually look at this again. Now, as far as lower levels, I don't know that I have an issue with that, but it seems to me if bureaus are being moved around and reporting to different people, that constitutes organizational change in the organizational chart. And I don't know, Derek, if you agree with that, but to me that sounds like the sort of thing that would require approval. If someone is no longer going to be reporting to the Director of Health, that by job description is now said to be reporting to the Director of Health, and by our existing org chart says that they're reporting to them, I have a little bit of an issue with that one.
I can tell you that there's been no implementation of any change in reporting relationships. The only 2 areas that have been reconstituted and created, and we've talked about this over a number of months, is the Strategic Planning and Evaluation Unit and the EPI unit. Other than that, those units never reported directly to the director. All other programs and units continue to operate as they have been structured. What has been happening in parallel to that are conversations among colleagues to discuss what these proposed changes may mean and how people could work together. So I just want to clarify that each of the current organizational chart members that exist on the organizational chart as passed in December of 2019 still exist, and they still have direct reporting responsibilities to me. And I will continue to follow up with you one-on-one and all of the board members. As for the one quick feedback on the medical administration role is that right now, each of these 13 members do report directly to me. So, for example, in the clinical cluster, the communicable disease clinics, public health, nursing, community health, each of those bureau directors report directly to me. And so, of course, I have that administrative responsibility and still do. In the looking at with Dr. Shaw Kai, she will be in a role, yes, as administrative, but not with the full administrative burden, because it will still be, more of a partnership and assistance and advisor. But the idea would be moving forward that, yes, those would report directly to that position, but that's not the way it is now. However, yes, we are talking and thinking through what these changes may mean. So I'll pause there.
I guess from that perspective, if these really are, in essence, by the elevated positions and new, then would that not warrant posting those positions? I'm just a little bit concerned we've got the cart before the horse here.
Yeah. That's what. Thank you for verbalizing that better than me. And as I've looked through it, you're right. I see this as 5 as well. Thank you for highlighting that, Mr. Frederick. And add on to your question, Mr. Frederick, I just want to make sure. I mean, those 5 senior leaders. I mean, my understanding they're already starting to meet, and I think maybe that's what you're also hearing, Mr. Frederick.
And I may have misunderstood, but I think that there are some individuals who may believe their reporting relationship has changed. I may have misunderstood.
Relationships and groups meeting in that. So maybe that's a good question to just get clarity on as well.
Yeah.
I agree with, for the sake of time, I'm not going to repeat. I agree with everything that my colleagues on the board have, the questions that you've asked, statements that you've made. I do want to add a couple of concerns. One, I just want to make sure that any proposed changes are from, and this, I'm not asking a question, so no need to respond, Dr. Caldwell. I just want to make sure that any proposed changes are from the vantage point of what is best for the department. And my concern, and it could have been the impact of the communications that we've had, was that this originated because you felt the burden of, to me, direct report, and not necessarily operating, or not necessarily making the changes from the perspective of what was best for the workforce. So that's my concern. I just want to make sure the tone is right. And also, I have a lot of other feedback I'm not going to get into, but the position for human rights and health equity, I'm just wondering how that originated. And we can talk about this later, particularly because when the board voted before you came on board to make sure that we have a bureau level position entitled racial and health equity. So there's a difference there, and I just don't want to lose sight because that was a directive from the board. So if we're creating positions, if we're renaming, we need to make sure that we take into account the decisions that we've already put forward. But I don't have any questions for you. I'm happy to refer back to you, Dr. James.
Thank you, Carol.
Yes, I just wonder, with these meetings that we're having individually, if I don't know how to make these more fruitful for you, Dr. Caldwell, and for us, because it's sort of like I was pretty floored when I saw this board design, because I was really happy to see one, but I was surprised that there were names attached to even very new positions in a whole change, as opposed to the organizational chart being explained in the rationale for it. So there are several levels of concern. And I really don't know the best way to try and support you in your efforts to mainstream the process. The mainstream is not the right word, but to facilitate a more productive and gratifying workforce design that everybody buys into. And I'm sort of where David Frederick is, that it doesn't sound as though you've had conversations, it doesn't sound like there's been a lot of buy-in by the people who will be working within this chart. So I'm just going to suggest that we sort of back up to that horse, or to the cart, whichever, and really look at the design and the purpose for the positions and what those positions are truly going to do before we put names to them. And please feel free to say, well, that's a real problem for me because of whatever. And I will listen to it, but I'm just really concerned about it.
All right. Well, I appreciate your feedback, and you'll continue to have these conversations with you. I guess one of the elements that I saw is outside of the assistant director position. And I guess the additional question about Dr. Bailey serving as continuation as medical doctor, but in the role of deputy director. The other three positions already exist, and so one of my thoughts would be just to kind of reassign duties. So that's one of the things I'm thinking about, and we'll talk to Derek and others to make sure that we're doing everything and aligned with the way we are able to. So I appreciate all your feedback.
And it would be nice to get resumes on folks whose names are on these charts. I don't mean everyone, but the chief people that are out there, at least one of them. I don't think I've ever seen a resume.
I'll make sure that those get to the board member.
Thank you.
Anyone else have any thoughts, concerns? All right. So while we're leaving this, I want to just one more time reiterate. ELT members, you have the month. From your board chair, please reach out to all of us. Martha can help facilitate. You probably have all of her emails as well. And if you'd like to speak publicly next Monday or next month, do this. And Dr. Caldwell, I hope you take what you're hearing with seriousness, because I think a lot of us have a lot of reservations. And I've expressed mine privately as well. And I am interested about that 6 month approval we did of an interim position that apparently is no longer interim. So I'd like more dialogue around that at another time. So with that said, any of my board members have any other discussion before we move on to the next this topic will again come up in November. All right, hearing none, I'm going to move on to Mr. Diamond. Please move forward with the grants and the contract.
Yes, Dr. John Gear, we do not have any applications this month, so I will move straight to the grants and contracts. I have 8 of them for you today for your consideration. Item number 1 is a grant from Hills for pet nutrition assistance related to COVID-19. Item number 2 is an MOU with Metro's water department for inspection of the dry pond located at Metro Animal Care and Control. Item number 3 is an affiliate agreement with the University of Nevada. And the next 5 are all community partnership fund grants. This year, the community partnership fund grants were taken out of our local budget, but we were authorized to use COVID money, the CARES Act money, to give grants to local nonprofits. And so items 4 through 8 are all COVID-19 Community Partnership Fund grants. So I'd be happy to answer any questions or concerns you may have with those. Yes, Mr. Frederick.
Yes, I just wanted to know what's the process for this granting and distributing these COVID funds. Are these programs that we fund, our partners we funded in the past and lost the funding, we no longer have it? So do people know they can apply for these funds? How does this happen?
Sure. And if Dr. Larson's still on, she ran, this, but we did send out solicitations to previous known not nonprofits who we work with or who we thought may have interest in it. It was posted on our website as well. So, Dr. Larson, would you like to add further to that?
Sure. No, you're absolutely right. We sent out to about 200 partners whom have been on our list. We also posted, as was mentioned, we actively reached out in regard to assuring that we had equity in our distribution. And all of that was taken into consideration on our scoring algorithm to assure that we were selecting the appropriate partners. We did, in fact, have 2 whom were previously funded. That was just how it rolled out. But we're real excited about the partners who are going to be performing a variety of work to meet this unmet need in Davidson County.
Quick question. Thank you, Celia. I'm just wondering if maybe you can work with Martha to email out, just so we can have an idea of the locations of the work that's going to be done in the grant, just so we can sort of see where in the city, who are the Nashville residents that are benefiting. That would be helpful for me. But in just something in an email is fine. I want to know a little bit more. It seems like really good work.
Yes, most certainly. I'll do that. We have Southeast Nashville is represented off the top of my head, versus also as well as the areas served by Tribeca in terms of high-risk youth. We also have a partner in North Nashville who is serves high-risk men, and I can get you a detailed list on that geography.
Thank you.
I've got a question. The jail health, since Core Civic is coming out and the health department's going to take over care, can we understand a little bit more about how that's financially going to impact the department, Jim?
Sure. The contract is managed by the health department. There is an agreement with WellPath, who provides services currently in the jails, that were previously operated by the sheriff's office. The Core Civic, former Core Civic facility, are state inmates, 1 to 6 years sentenced. So those monies were provided to the state, or from the state to the sheriff's office as part of operating of that facility. So this won't come directly out of health department appropriations. It won't affect any programs that we currently have. It's more of moving money that went to the sheriff to pay Core Civic. So now it's just being routed all through Metro to WellPath. So was that your question or concern?
Yeah, that was exactly what I was looking for. And I'm just curious as to how can we get linked to the University of Nevada?
We have an employee who is doing some master's work, and she's doing school through the University of Nevada, and part of her school work is going to be centered around some of the work the health department is doing. So, and she would be doing this in her off hours, but since she will be working using health department interpreting some data, that's why we needed to have the agreement in place.
Okay. And my last question is, I don't have the actual thing, I just have my notes in front of me, but Department of Health says that there's a possible vaccine by mid-November. And what is that about, that mid-November, and that we might be involved in working with that vaccine, and which vaccine is it?
I'll take this one.
Yeah.
So the state has notified us that they could receive vaccine as early as the 10th of November for distribution. They expect to receive up to enough to vaccinate about a third of our first responders / high-risk individuals. The state's developed MOUs with a number of the hospital systems and will directly ship to them, but we would have responsibility in a closed pod or POV situation to provide vaccine for our first responders, such as EMS, police, etc. That's at earliest. A vaccine has to be approved for emergency use at the very least. And the FDA is actually looking at putting in place an extra step that may prolong that by several weeks or a little bit longer. There are currently 2 vaccines that are in phase 3, Pfizer's vaccine and Moderna's vaccine. Pfizer's is supposed to read out their results as early as the end of this month. with Moderna's reading out sometime a couple weeks later. Pfizer has gone at risk thinking that their vaccine will actually work, and they are actually producing the vaccine right now, even though they don't have any approval or any insight into whether the vaccine is going to completely work or not. Moderna is not doing that. Also, Moderna did take, I believe, took some funds from the federal government, but Pfizer did not take any. So the Pfizer vaccine, as much as the current administration talks about wanting to push things up, they really have no leverage on the drug company to do that. And both are very similar in their mechanism of actions, and we haven't heard a lot of side effects from these. So I think they're going to be very safe. The biggest drawback to Pfizer's is it has to be stored at minus 80 degrees. We have ordered and are in the process of receiving super freezers to be able to handle the vaccine if and when it becomes available.
Okay. Dr. Ryan.
Can I hold off for a second? Is this relevant to the grants? Or we still have to vote on grants and so forth? I'm sorry if I'm just want to make sure that.
I'm just looking at my notes and then find enough.
That's in the update.
I want to keep us on task here, and I'm happy to have dialogue in just a minute. But is there any other questions about the grants?
Okay. Second.
All right, so Ms. Franklin for approval of all these grants is presented by Mr. Diamond. All right, I'm going to go on my list here. You guys have moved around. Dr. Smith.
Aye.
Ms. Etherington.
Aye.
Mr. Frederick.
Aye.
Ms. Franklin.
Aye.
Dr. Campbell.
Aye.
And I as well. Okay, thank you. So grants and all and contracts approved. Now, we have Dr. Caldwell's report written. Dr. Caldwell, you want to give a quick touch base on a certain part of it real quick, and then we can open up for dialogue then? Ms. Etherington, that'll be fine.
Sure. Sorry. I really
Yeah. So Dr. Caldwell, please.
Yes, it's my pleasure to introduce our new epidemiological director lead, Dr. Rand Carpenter. You approved his salary at the last board meeting. He's here with me in the room. I'm going to ask him to come up and formally introduce himself to you. Just one moment. Look right into it.
Okay. Great. Good evening. I'm proud to be here. Thanks very much to Dr. Caldwell and Dr. Bailey and you, the board, for giving me this opportunity to join the health department. I've been working in global health for the last few years, and I'm glad to be back re-engaged here in my home community in Nashville and back doing this local public health work from an epidemiological perspective. I've got some experience you might remember from the state health department and CDC, and there's a lot of capacity and energy here, and I'm looking forward to continuing this work. So thanks very much.
nice to have you.
Welcome.
If anybody has any questions, I'm glad for that, but thank you.
Thank you, Dr. Carpenter, for joining us, and thank you to the board for approving his recent request for the salary. I did want to just take a moment, because I'm not sure all the board members know about the many lawsuits that the department is involved in with citations, but not only is I am being sued by an entity representing a lot of the downtown bars as the director of health, but I'm also being sued personally. So that has required me to get my own personal outside counsel, which I've worked with Metro Legal to assure that they can coordinate with that. So that may be something that the board members just were not aware of, that I have incurred that personal liability for being sued personally in addition as a director. of Health. So I'm happy to answer any questions if this is news to you or you have any thoughts about that.
It is news.
And I think for me at that appropriate time, I would like more information, more details regarding that particular lawsuit and any others that might be out there.
Okay, I'll work with our Metro Legal to make sure that we have some kind of summary that we're able to provide to you to keep you updated on the many suits that are coming in. As for our efforts with the compliance with face mask distribution and the compliance teams, we have a great infrastructure through the mayor's office, as well as Metro Legal with Bob Cooper chairing a committee with Kristen Wilson in the mayor's office that composed of about 10 different Metro agencies. So really over the last 6 weeks, there's been a major transformation in our ability to be effective throughout the entire county with face mask compliance and other enforcement issues. And we're really pleased at this transformation, and it's working very well for our environmental division as well as so many others. We have probably a pool of at least 25 individuals who sign up every Friday and Saturday for a Broadway mass distribution, and as well as any other events, usually from 6 to 10:30. Each board member, as well as all of you who are listening, can sign up to help us, whether you're an employee or just want to volunteer. We'd appreciate you helping us out if that works for you and something that you'd like to do. It's provided a great team building opportunity as well, because we've gotten staff from all levels of the department, as well as all different programs across the department. It's provided for new sharing of ideas and new friendships and new ways of us getting to know each other. And as an example, what we had is a couple colleagues from the sexual health clinic wanting to not only just give out face masks, but also brought condoms to give out as well. So I was really pleased about that partnership, that creativity, those ideas of how we can use these efforts for COVID face mask compliance to help us reach out more with some of our other programs as well. As for COVID testing, that continues to be managed well, thanks to Dr. Gil Wright for being our main interface with our colleagues at Meharry, for all the community assessment centers and the Office of Emergency Management. Thanks to you for continuing to provide the main oversight for that. We're already gearing up for the flu vaccines. A number of board members have already taken advantage of getting your flu vaccine. Thank you for demonstrating your leadership and getting your flu vaccine early and at the Department of Health. We're going to be joining the state of Tennessee through their flu vaccine day on November 19th. Plans are being put together now, but we're hoping to be able to use one or more of our current COVID community assessment centers to also do drive-through for the flu vaccine. And that will hopefully preview for us everything we're doing with the flu vaccine, of how we can use that as a window for us to figure out how to really do a great job when we do get the COVID vaccine, how we can have different ways to provide that to the community over time. There are a number of items that are written on the director's report. I'm happy to talk about any particular one of those. Ones that have been discussed before were that we are transitioning our results line staffing and our temporary staffing, which provides results to people who took tests at the assessment centers, to a company that's used by the Tennessee State Health Department. That contract is in its final stages of being signed, and we hope that transition will happen very soon, within the next week or so. We are really excited about school returning. There's that phased-in approach of students going back to school. And of course, you know that we have a great program of school nurses and a school nurse program. And we are working right now with every school to make sure that they have their safety plan in effect, that they know what to do in case somebody has any symptoms or tests positive, how they can work hand in hand with all our contact tracing efforts. And also, there's been a lot of support for advancing the school nurse in every school program. So yeah, they're hoping right now that we might be able to use some a constellation of some of the COVID funding as well as some additional funding. Our team is preparing to ramp up very quickly if we get the approval to be able to go ahead and add a lot more school nurses quickly. So there's plans in place for that as well. There's probably a few other items of interest. You probably have seen that we have had a new public health order to expand access to people that go to having more events up to 500. There's a great portal system on the safenashville.org website where you could submit your events. Anyone who's having an event over 25 people needs to submit their event, hopefully within 72 hours at least or more of the event, up to 500. And on a case-by-case basis, we might be continuing to do strategic pilot programs that are going to be more than 500. What stands out there is at Nissan Stadium that welcome back fans on Tuesday with Nashville soccer. And of course, when the Titans are back there again, that they will, of course, have more than 500, up to about 10%, we're thinking right away initially. We are also working with the Opry. As you know, they have opened up and welcomed fans this last Saturday and looking again to have more people this Saturday. And we have had 350 submissions of events. Really a wonderful team led by Tom Sharp and Mr. Hugh Atkins, environmental health team, as well as our technical assistance advisory support team on reopening. And I'd invite you to go down to the Charlotte room, which is on the first floor during business hours, to see the 9 individuals there in our emergency operations center and the great work they're doing to be able to respond to complaints as well as to evaluate all of these submissions in a very timely fashion to work with and educate all of these individuals that are putting on events to assure they could put on the safest event possible to protect their workers and the people who are going to be coming to their particular events. I've been really pleased at the work that everyone in our department's doing and the partnerships of all those in the community. We have not turned down any event that has asked to be submitted. What we've done is worked with the event sponsor to make it a safer event and tailor it so that we felt comfortable and that they felt it was something manageable for them to do. Finally, of course, Belmont, October 22nd, Thursday, supposed to have the last presidential debate. It seems that the news is changing hour by hour on whether that will take place or not. I had a meeting at HCA with Belmont and other members of the presidential debate task force team to be able to lead the health security for the event. And I'm working with our team here as well as Nashville Fire, EMS, and Metro Nashville Police Department to assure that whatever testing protocols are needed to assure the health security of that process. And it's not just a one day, it's a multi-day process that we're gonna accomplish that. And I'm happy to pause there and answer any questions, Dr. Jahangir.
colleagues?
Last month, I asked for an update regarding community research associates and how we're progressing with that conversation. Do you just have a quick sentence or two to let us know what's going on with clinical research associates?
Yes. We have worked with clinical research associates to identify someone in the community that they have brought on part-time to work to make more connections with the immigrant, Hispanic, and African-American communities specifically to help with their recruiting efforts. So we are also assisting them with any interpretation services. They are working with Pfizer and AstraZeneca, as you know, on their trials. The Pfizer one, they have not needed our clinical assistance with, although we are prepared to assist if needed. That's not needed at this time. They just want the continued assistance with us connecting them with more potential volunteer participants. And also, the AstraZeneca study is paused. It has not been restarted in the United States, so therefore that has not become necessary for us to participate with them. But I do know Clinical Research Associates has had a number of other inquiries over the last couple of months with other companies, and I'll keep the board updated if any of those look like they're going to move forward at all.
Just to be clear, are we assisting with recruitment efforts, or are we providing consultation based on racial equity, cultural humility about and community engagement strategies with clinical research associates?
Well, our efforts to amplify recruitment is broad-based, not just for clinical research associates. It's for all of the sites that are trying to recruit. I know that Meharry has taken a real leadership role in this, and their work was highlighted recently on a national story on National Public Radio. So we are working to assure as much as we can to have each of the sites that are recruiting volunteers for the COVID vaccine research studies, that they can be in touch with and assisted with any way we can to help them with recruitment efforts, broad-based, but specifically with their targeted need to identify more minority candidates for volunteers. I'd also bring to your attention that a couple weeks ago, Mayor Hooper had highlighted the clinical vaccine research trials, and that you can find information on the asafenashville.org website. There it says, learn more about volunteers for research vaccine trials, and there's portals for the 3 local sites still actively recruiting for volunteers. I know all of them very much want to have as diverse a pool as possible. And in addition to the 3 local sites, there's a link there for the National Institutes of Health site as well to provide more detailed information. Thank you.
Thank you. Any other questions? Carol, I don't see you. I know before you asked a question. Or did I see Tanae's hand?
Just real quickly, so this is we're honoring or recognizing 2 months, one Hispanic Heritage Month. I'm wondering if there are any activities in the health department around Hispanic Heritage Month, and also the Breast Cancer Awareness Month. Just wanted to make a plug in to make sure that people are doing their due diligence with regards to self-exams and mammograms and just supporting survivor families. So if there are any efforts in the department around Breast Cancer Awareness Month or Hispanic Heritage Month, that would be great to highlight our work for.
Thank you. So let me just, I don't know if you heard some feedback. Hispanic Heritage Month comments, as well as Breast Cancer Awareness Month. Anything? Thank you.
Hi, this is Tina, and I just wanted to let you know that we do have a breast and cervical cancer coordinator here at the health department, and we do have activities that will be going on all month long through her work here.
Yes, thank you, Tina. I think you solved the problem. And as you could see, I'm wearing a pink tie. Wearing right away the last week with the beginning of Breast Cancer Awareness Month. I'm promoting it myself individually, as well as I'll be working with our breast cancer awareness team to identify other places that we can amplify the message. And as for the National Hispanic Awareness Month, I'm not sure if anybody else has more detailed information on that program. Hearing none, I will follow up on that specific issue. Was somebody else going to comment?
Yeah, I just want to say thank you and just wanted to just honor and recognize those in the department that identify with being Latinx in celebration of the Cancer Month. And, thank you. I would love to maybe just in a quick email just highlighting the activities that that health department is doing this month, just so we can be aware and maybe share it out broadly. Thank you.
Okay. It's Doris Campbell. I'm sure you're familiar with Doris, and she usually does activities during the month of October. Also, we have usually some type of promotion through the Coleman Foundation. We have team captains that will raise money for us to give to the Coleman Foundation, Susan Coleman Foundation. So we have several things going on, and I'll make sure you get an email about it.
Thank you. Any other thoughts or discussions with Dr. Caldwell during the director's report? And I'll move on to mine once if I hear none. Okay. Well, my report's very quick. I just want to reiterate, I can't overthank this department and all these people on this call and the many people we don't see. I mean, I've had a very unique opportunity over the past 7 months to get to know you guys all so well. So thank you for all you do. One person who I found out today is leaving is Ashley Harrington, from MAC, who I don't know if you're hearing me speak, and if you're not, if you are, I'm glad, and if you're not, I'd love for somebody to tell her that. But I've had an opportunity to watch what Ashley's done for MAC over the past many years. I've been on the board. I believe she went to the fire department and to fire academy. So I'm very thank you for leaving MAC to go literally save Nashville. And so I'm very grateful to her for everything you've done. And I suspect I can speak on behalf of the board. Wish you well and thank you. And I think that's just, I'm excited for the fire academy. I'm less excited for our department, but I'm sure we'll find somebody wonderful as well. So again, this position has allowed me to meet some really amazing people. Ashley is one of them. So thank you. I think you guys are getting the COVID updates. We're at a relatively stable yet cautious place. So we're moving along there. Anyone have any questions of me? And if not, I want to move on to the board request, but any questions of me before I move on? Okay. The board request I've seen, and Martha's already done this, is we asked for an understanding of what we agreed to when it comes to the data sharing protocol. Martha has already emailed that to us. Thank you. But we will get from Mr. Durbin next week an understanding of where we are heading, and all of us will review it. But Dr. Campbell, I'm going to lean on you to please make sure it's consistent with everyone's understanding and agreement. And then we can figure out how to move forward from there. Yes, Mr. Frederick, I see your hand up.
Yeah, I just want to be sure that we don't really put the total burden on Mr. Durbin, because I think he really can only answer the first three of our 5 points here, and the other two about having independent committee auditing and employee tracking. I think that's more incumbent upon us and not him. So
Thank you. Thank you for pointing that out, and I am glad you brought it up earlier. And Mr. Urban has served a role for us, and I'm grateful. But you're right, the onus falls on Dr. Caldwell department and us as for oversight. So, how best? How do you want to move forward with that specific issue of review, or anyone is?
I'll speak from my perspective. If someone can. And I would say it's Dr. Caldwell, or I mean, he can have someone else do it for him, but then it should come from him. I would say that we understand how these 5A through E, how those 5 points are being addressed with the plan, and if they are satisfactorily addressed, then we're good to go. From my perspective, in writing, of course, but so that we know what's happening, so we see the plan laid out against these 5 questions.
That's fair. Dr. Caldwell, I'm going to put that on you as one of the board requests, please. Is that fair, team, colleague?
Yes, and I will look into that. And if we need to reach out again to Dr. Campbell for review at the committee, I'll ask that be done. But let me look into that.
Yeah, I hope it doesn't have to be review of the committee again and again. I think just we've all agreed to what we want and expect, and based on what Mr. Durbin says, maybe just report back to us, please, on to the 2 with a clear written understanding of how this is being implemented, and we'll compare that to how we were hoping it was going to be implemented, and then we can discuss further. Is that fair?
Yeah, I'll have that, and then I'll present that to the board before the next meeting.
All right. Any other questions? Thoughts?
I think that we want this implemented as soon as possible. So rather than the next meeting, I think we were talking about being able to do this via email, perhaps as early as next week.
I think next week. That's right. Thank you for pointing out. Yeah, I think we need this information next week. But I want to be very clear. Until we see that email, until I guess I give a green light, which I will figure out how to make sure everyone's on board. Please don't implement anything. I just want to be very clear with that. Let's all just review it, and then we'll roll forward. But until we need to see all that. Okay.
We got it.
Thank you. Anything else? I'm going to adjourn the Board of Health meeting and call to an order to Civil Service Board. Mr. Diamond, you got 2 things. Go for it. And you're still muted.
Sorry about that. First item is department is requesting approval of an extension of administrative leave for an employee facing a disciplinary hearing. The department and the director thought it would be in the best interest of the department to have her on administrative leave prior to our hearing. And Civil Service Rule 5.13 says that the board must approve any administrative leave beyond 10 days. The hearing for this employee is scheduled for October 13th, and the hearing officer has 10 business days in which to render a decision. So we would request the board approve the extension of administrative leave through October 27th, which would be the 10th business day following the October 13th hearing.
Okay. Any discussion?
We were just we're trying to catch up. Yeah. And so I know we're not mentioning names, but just we don't have anything in our packet regarding this particular item. So could you just provide us just a little bit more background, Jim?
I can provide some. It's our clinic manager in the TB division, and there's some performance issues and concerns there, which is why the disciplinary process is taking place. And so with the kind of work that is being done in the TB clinic and the concerns that that was why the management requested Dr. Caldwell place this employee on administrative leave prior to the hearing.
I would move approval. Second.
All right, Mr. Frederick and Ms. Etherington, any more discussion around this? Okay, roll call. Dr. Smith?
Aye.
Mr. Frederick?
Aye.
Ms. Franklin?
Aye.
Dr. Campbell?
Aye.
Ms. Etherington? And I'll also aye it. Thank you. Okay, personnel changes?
Yes, there September personnel changes are in your packet, and I'll be happy to answer any questions or concerns you may have on those. This does not require a vote, so if there are none.
Okay, thank you. All right, I'm going to adjourn this meeting. Thank you. Have a good day, everyone.
Thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.gov.